Good morning. Today seminar is on biochemistry of renal stone disease. My name is Inshallah Alamra and my moderator Dr. Getachew Surgeon. Let's continue today's seminar. So in this seminar, these are the outlines that we cover in this seminar, and it is the objective, main objectives end of the session. So kidney stones is a solid concrete or crystal aggregation formed in the kidney from the dietary minerals in the urine. And these kidney stones have different names. Sometimes we can use these names alternatively. Renal lithiasis, renal calculi, or nephrolithiasis. And the common cause of visit to the emergency department. This renal stone is a common cause for visit of renal in the emergency. So stone formation is governed by the physical chemistry characteristics of urine in the upper collecting system, and most stones are formed by minerals or stone forming cells and begin to crystallize when there is the concentration becomes supersaturated in the urine. So when you see the epidemiology, the lifetime prevalence of kidney stones is estimated to be 1% up to 15%, and in the USA 8% from the data taken 2007 up to 2010, and this prevalence has increased with factors such as global warming, poor diet, stress, and obesity. Most recent data revealing a stone prevalence of 10.6% in men and 7.1% in women, and a stone occurrence is relatively uncommon before age of 20, that peaks in incidence in the 4 to 6 decades of life. So kidney stones occur most commonly in men than the women, and whites have the highest incidence compared to others. And prevalence of stone disease shows the geographic variability, with the highest prevalence of stone disease in the southeast. Most of the time, this prevalence is because of the content of the water. Hard waters are preventive for stone disease, or there is decreased stone in the water was hard stones. The risk of stone disease is correlated with weight and BMI, and stone disease has been correlated with a number of systemic diseases like diabetes, metabolic syndrome, and cardiovascular diseases. When you see the risk factors, there are different risk factors that leads to the renal stone, and some of these are the dietary risk factors such as low calcium intake, high oxalate intake, high animal protein intake, high sodium intake or low fluid intake, higher sucrose, higher fructose, higher vitamin C, and the urinary factors are low volume, urinary volume, higher calcium or calciuria, higher oxalate, lower citrate, and higher pH. The anatomical factors, there are also anatomical factors that predispose to renal disease: the medullary spongy kidney and horseshoe kidney. Medical conditions: primary hyperparathyroidism, gout, obesity, diabetes, as I have said before, and the history of prior or history of nephrolithiasis. That means there may be recurrence. Family history of stones, upper urinary tract infections, drugs, hot environment, and other enhanced enteric absorption like GI surgeries, gastric bypass procedures. So let us see the biochemistry of stone formation. So the physical process of stone formation comprises a complex cascade of events. These are the state of saturation or nucleation and crystal growth and aggregation and retention. So when you see the supersaturation, almost, for example, if there is a small amount of sodium chloride dissolved in the water at a given patient temperature. And if we add more sodium chloride at a point, we'll reach at which sodium chloride will no longer dissolves. So this type of solution is called saturated solution. In saturated solution, the equilibrium exists between the dissociated ions and the solid compound. So the equilibrium expression for this saturation solution is as stated. So the ions sodium and chloride within the solution, the sodium chloride solution. So there are different terms that we have to understand before we understand the biochemistry, like the solubility of ion product. What is it? Is the ion product at a saturation at a specific temperature. This is the solubility ion product, and concentration product is the solution containing ion or molecule of sparsely soluble salt. And supersaturation means it is the solute concentration in which above that would ordinarily result in precipitation if the solution were held at the equilibrium. And formation air product is the saturation ion product point at which the spontaneous crystal nucleation will occur. And under saturation is a solution when the concentration is less than the solubility product. Crystal nucleation will not occur at this point. And the meta-stable region is the area between the solubility product and the formation product. So the next cascade or the next series or the next step is nucleation and crystal growth. So a solution with a concentration product that is greater than the formation product is quite unstable, and crystal nucleation will occur spontaneously. Crystals in the urine result from nucleation, and the initial step whereby the urinary constituent transforms from the liquid to the solid phase in the supersaturation solution. So crystals cannot grow to reach a size sufficient to occlude the tubular lumen in the transit time, which is 5 up to 7 minutes is the transit time. And there are inhibitors that prevent the process of crystal and growth and aggregations. So it was initially concluded that free particle stones formation was impossible within the normal transit time through the nephrons. But supersaturation in crystal growth rate determined that the crystalline particles can be formed to retain the nephrons. So there are different two types of nucleation: the homogeneous and the heterogeneous nucleation. When you say the homogeneous, when the process occurs spontaneously in the pure solution, the same solution. Heterogeneous is a mixture of several different crystals within one or two prominent constituents. Example, mixture of calcium oxalate with calcium phosphate. This is heterogeneous nucleation. And formed crystals either can be excreted the, in the urine as a crystal urea or grow in the and aggregate to become clinical ketones. So they may excrete in the urine or they may aggregate and grow. So if they aggregate and grow, they produce or they form the stone. And in the aggregation, crystal nuclei will bind to each other to form the large particles. The crystals bind to form the large particles, and this process called aggregation. And crystal aggregation likely plays an important role in Einstein. So this is an important role for the stone formation. Highly aggregated structures are noted in microscopic examination and ultrastructural analysis of renal stones. They found that all caliculi have three distinct zones: the core zone, the intermediate area, and the, the peripheral layers. So when we examine the structures, there are different zones that we see in the caliculi. The other is next is crystal retention. Crystal retention will result if the crystal grow large enough to be trapped in the renal tubules or if they adhere to the urothelium before excretion. So the earliest evidence of crystal retention was the finding of macroscopic plugs of the subepithelial deposit of calcium crystals in the renal papillae by Randall in 1940. So crystals formed in the urinary tubules can be retained in the tissue from the apical to the basement side of the tubular epithelium. He proposed that these calcific deposits originate in the damaged renal tubular epithelium basement membrane. So if after they retained, they causes renal tubular damage and later erode into the urinary collecting system. And these plaques, known as Randall's plaque for the urinary stones, are thought to serve as needles for urinary stone formations. Opposite to that, inhibitors prevent the formation of stone. So the presence of molecules called inhibitors prevents stone from occurring on the routine base. That is why this is help to not form the renal stones in everybody. Inhibitors have been identified that prevent calcium oxalate and calcium phosphate crystallization, but no specific inhibitors are known that affects the uric acid crystallization. And additional interference with the site of adhesion of crystals to the renal epithelium can prevent calculus retention and growth. So when the uh, retention and growth is prevented also in the site of adhesion, stone formation will be prevented or inhibited. There are different inhibitors that prevent stone formation. Inorganic pyrophosphates was found to be responsible for 25 up to 50% of inhibitor activities in the calcium phosphate. And citrate also an inhibitor of calcium oxalate and calcium phosphate stone formation by different mechanisms. The first is it directly inhibits the spontaneous precipitation of calcium oxalate. The other is it complexes with by the calcium, then prevent interaction with oxalate and phosphate. So if the citrate complexes with the calcium, so the calcium has no place to formation with oxalate and phosphate. The other is prevents heterogeneous nucleation of calcium oxalate by monosodium urate. So not only this, there are also magnesium phosphate also has a role in as inhibition factors. Important inhibitors of crystalline nucleation growth and aggregates are for specifically in different step of stone formation, like crystal nucleation, growth and aggregation, nephrocalcin, uropontin, and TAM uh, horsefall proteins are also the important proteins that found in the urine and potent inhibitors of calcium oxalate monohydrate crystal aggregation. And but not this horsefall is not acting to inhibit the growth. Renal calculi consists of both crystalline and non-crystalline components. Then the non-crystalline component is termed the matrix, and which typically accounts for about 2 and 2.5% of the weight of the stone. And in some cases, the matrix comprises the majority of the stone, up to 65% usually, in associated with chronic urinary tract infections. And the exact composition of matrix is difficult to ascertain because only 25% is solid. So this is a summary how the stone is formed. So urinary supersaturation, then the crystallization formation, nucleation, crystal aggregation and growth, then crystal retention, then this finally the stone is formed. Let's go to the pathogenesis of the stone or renal stone. So there are different classification of nephrolithiasis. So from this, The most common component of urinary calculi is the calcium. About 80% of the stones is containing the calcium, and the calcium oxalate is about 60% of all stones. And mixed calcium oxalate and hydroxyapatite 20%. Both uric acid and struvate or magnesium ammonium phosphate stone is each contains 7%, and the brushite stone is 2%, and cystine stones are rare, which is about 1%. Stones associated with medication and other byproducts also uh, has low. It is very uncommon, but it can be caused by different medications and their byproducts. When it is a calcium stone, the normally we can classify calcium stone. We can classify stones calcium and non-calcium. So calcium oxalate, calcium phosphate, and others are calcium stones, and the others is non-calcium like uric acid stones. Cystic stones are non-calcium stones. So the calcium stones. Uh, so the mechanism or how these calcium stones formed by different mechanisms or the causes. The first is by hypercalciuria. So when you say the hypercalciuria, when there is greater than 200 milligram of urine calcium per day after adherence to 400 milligram calcium and 100 milligram sodium diet for 1 week. And high urinary calcium concentration leads to increased urinary saturation of calcium cells and reduce urinary inhibitor activities. And it occurs in 35% to 65% of the patients. So hypercalciuria is a common cause for the calcium stone formation. There are three distinct subtypes: the absorptive hypercalciuria, the renal hypercalciuria, and the resorptive hypercalciuria. So when it is the absorptive hypercalciuria, is defined by increased urinary calcium excretion, which is by greater than 0.2 milligram per milligram creatinine after an oral calcium load. After oral calcium load, if the excretion of urine calcium in the urine greater than 0.2 milligram per milligram of creatinine, we call absorptive hypercalciuria. Severe forms of absorptive hypercalciuria may occasionally be associated with fasting hypercalciuria, which is greater than 0.1 milligram per deciliter of glomerular filtration. Then the underlying pathophysiologic abnormality in absorptive hypercalciuria is increased intestinal absorption of calcium, which occurs in approximately 30% of stone formers. The cause of increased intestinal absorption of the calcium is by upregulation of the vitamin D receptor, and renal phosphate wasting lead to the subsequent increase in the active vitamin D. The second cause is renal hypercalciuria. So this is due to the primary leak of calcium, but then the cause is not really known. And the kidney filters approximately 207 millimole of calcium and must reabsorb 95% of it. So the remaining will not absorb it. So impaired renal tubular reabsorption of calcium resulting in elevated urinary calcium levels lead to secondary hyperparathyroidism, characterized by normal sodium calcium levels remain and high fasting urinary calcium. So if there is normal calcium serum level and high fasting urinary calcium levels, may consider the cause renal leak. Different diseases are in this renal leak are associated with hypercalciuria. The dent disease or the sex-linked recessive nephrolithiasis is linked to there is a defect in chloride channel, and there is it is estimated or it is expected that there is the loss of parathyroid as it during in the urine, and this loss of parathyroid causes for hypercalciuria. The other is familial hypomagnesemia with hypercalciuria and nephrocalcinosis is caused by the mutation in calcidin 16 calcidin genes. These genes are important for the formation of the renal tubules formation. These genes are important for the proteins production for renal tubules. So if there is no production, the gap in the renal tubule, so calcium leak or renal hypercalciuria will occur. The other is the Bartter syndrome, autosomal recessive disorder involving dysfunction in the thick ascending loop of Haley. So these are other diseases associated with renal leak, which causes renal hypercalciuria. The other is resorptive hypercalciuria. It is associated with primary hyperparathyroidism, and the primary hyperparathyroidism is a cause of nephrolithiasis in about 5% of the cases. And the diagnosis of this hyperparathyroidism, primary hyperparathyroidism, should be suspected in patients with nephrolithiasis and serum calcium level greater than 10.1 gram per deciliter. And excessive parathyroid hormone secretion from the parathyroid adenoma leads to excessive bone resorption and increased renal synthesis of the vitamin D3. So enhanced intestinal absorption of the calcium, and the net effect is elevation of the calcium, urine the calcium level, and reduce serum phosphate levels. There is a thiazide challenge test to diagnose this. By administering of the thiazide diuretic will enhance renal calcium absorption and exacerbate the hypercalcemia to diagnose the primary hyperparathyroidism. In this situation, then there is normal serum calcium level during inappropriate hyperparathyroid serum level. So in the resorptive hyperparathyroidism, there are different diseases that are associated with this. These are the sarcoid and granulomatous diseases, malignancy associated hypercalcemia, and glucocorticoid induced hypercalcemia. So in the sarcoid, granuloma produces the vitamin D from 1-alpha hydroxylase present in the macrophages of the sarcoid granuloma. So there is this vitamin D production increases the serum calcium level. Sarcoidosis differentiated from the other granuloma disease by rapid resolution of hypercalcemia with initiation of corticosteroid therapy. And tumors, also others, malignancies in patients with humoral hypercalcemia produces parathyroid-related proteins, and these proteins activate the osteoclasts and increases the calcium level. Lung and breast cancers accounts for about 60% of malignancy associated hypercalcemia, whereas the renal malignancy is 10 up to 15% that causes hypercalcemia. And direct mechanical destruction of bones constitute bone cause of hypercalcemia. Also, there is direct mechanical destruction of bones also cause hypercalciuria. The other is glucocorticoids. They alter calcium metabolism through their action on bone, intestine, and parathyroid glands. And their most potent effect is in bones by promote bone resorption, reduce bone formation, and leading to osteopenia with chronic use of glucocorticoids. Additionally, they stimulate release of parathyroid, and stones were found in 50% of patients with the active Cushing syndrome. By taking glucocorticoids, they may develop Cushing syndrome, and in Cushing syndrome, 50% stones are observed. So the other cause of calcium stone formation is hyperoxaluria. Hyperoxaluria defined as urinary oxalate which is greater than 40 milligram per day and which leads to increased urinary saturation of calcium oxalate and subsequent promotion of the calcium oxalate stone. So there is increased calcium oxalate in the urine. The membrane injury facilitates the fixation of calcium oxalate crystals and subsequent crystal stones. So if there is hypercalciuria, there is membrane injury or damage to the membrane, and it is very important to the crystal formation by retention and growth. The causes of hypercalciuria include primary hypercalciuria, enteric hypercalciuria, and dietary hypercalciuria. So when it is enteric hypercalciuria, the most common cause of the acquired hypercalciuria is enteric hypercalciuria. This abnormality is associated with chronic diarrhea states, in which fat malabsorption results in saponification of fatty acids with divalent cations like calcium and magnesium, and also increases colonic permeability to oxalate, then enhance intestinal oxalate absorption. By this mechanism, the chronic diarrhea can cause hypercalciuria. Therefore, small bowel rejections, interstitial diseases, and jejunal bypass have been associated with hypercalciuria. Primary hypercalciuria is another cause. The primary hypercalciuria is a result of rare autosomal recessive disorders in glyoxylate metabolism. So this glyoxylate metabolism should be converted to the glycine, but by the autosomal recessive disorder, this glyoxylate is converted to oxalate. So this increases the level of oxalate. So consequently, markedly high level of urinary oxalate will occur in this primary hyperoxalate greater than 100 milligram per day, and leads to increased saturation of calcium oxalate, aggressive stone formation, and marked nephrocalcinosis. When you see the nephrocalcinosis, the crystals formed by the stone, they are retained in the tissue or in the tubular tissues or in the renal in the nephrons and in the interstitium, and therefore this calcinosis. Renal injury may be a consequence of direct cellular toxicity from either high oxalate concentration or calcium oxalate crystals. So calcium high oxalate concentration increases the renal injury. Renal impairment occurs from recurrent obstruction of the calcium oxalate stones or as a result of renal parenchyma infection, and the other is interstitial fibrosis from severe uh, nephrocalcinosis. So the renal impairment due to hyperoxaluria is by these mechanisms. The next is dietary hyperoxaluria. The overindulgence in oxalate-rich foods such as nuts, chocolate, and others resulted in hyperoxaluria in normal patients. Dietary oxalate contributes about 24 up to 40% of urinary oxalate excretion. So severe calcium restrictions. Calcium restrictions may result in reduced intestinal binding oxalate and increased intestinal oxalate absorption. So calcium intake is not prohibited in renal stones. If there is restriction of calcium stones, calcium intake, there is reduced intestinal binding oxalate, so there may be a reabsorption of oxalate from the intestine. So dietary hyperoxaluria by taking different oxalate-rich foods. So increased animal proteins can also increase urinary level of calcium and oxalate. The other mechanism for the calcium stone formation is hyperuricosuria. Hyperuricosuria is defined by urinary uric acid exceeds 600 milligram per day and up to 10% of calcium stone formation have high uric acid levels as the only abnormality, a single cause, if there is a single cause, but combination with the others, the percent of uric acid will increase. Hyperuricosuriia increases urinary levels of monosodium nitrate, which is in turn promotes calcium oxalate stone formation. At a pH less than 5.5, the undissociated form of uric acid predominates, lead to uric acid and calcium oxalate stone formation. At a pH greater than 5.5, sodium urate for the sodium urate formation promotes calcium oxalate stone formation through the heterogeneous nucleation. The other mechanism to form the calcium stone is hypocitraturia. Urinary citrate levels less than 320 milligram per day is defined hypercitraturia, and the hypocitraturia is abnormally associated with nephrolithiasis in up to 10% of the calcium stone formers. And citrate, as I have said before, is an important inhibitor that can reduce calcium stone formation by several mechanisms. These are the first is by the citrate reduces urinary saturation of the calcium salt by complexing with calcium. The second is the citrate directly prevents spontaneous nucleation of calcium oxalate. The third mechanism is citrate inhibits the agglomeration and sedimentation of calcium oxalate crystals. By this mechanism, the citrate used as an inhibitory mechanism for stone formation, but if there is hypo or low level of citraturia, this may be a cause for calcium stone forms. When you see the medications that promote stone formation, there are some medications that directly crystallize in form stones, and the other medication have also other mechanisms from their byproducts. So medications indirectly promote stone formation by increasing urinary stone risk factors. Some of these are by corticosteroids, vitamin D, phosphate binding antacids can induce hypercalciuria. By forming other risk factors for the stone formation, some medications causes the stone formation. Thiazides causes intracellular acidosis and subsequent hypocitraturia, and loop diuretics such as furosemide and bumtanide inhibit sodium and calcium resorption in the thick ascending loop of any, within which is addition to the diuretic effect of hypercalciuria. There is a drug called indinavir. Indinavir is a protease inhibitor used in the treatment of RV patients or in HIV. Indinavir stones are soft and gelatinous, and they are radiolucent on X-ray. X-ray examination of the kidney or the QB X-ray, as well as on the CT. And indinavir stones are virtually the only urinary stones not visible on CT. And triametrin, a component of diazide, may also produce radiolucent stones. So this indinavir and triametrin are stones that this directly form crystal and form the stone. The other is renal tubular acidosis. There are this is the clinical syndrome where there is the renal tubular acidosis by the secretion of hydrogen ion and by decreased reabsorption of the bicarbonate. And there are three types of renal tubular acidosis: the type 1, type 2, and type 4. The type 1 is called distal renal tubular acidosis, and the type 1 renal tubular acidosis comprises syndrome of abnormal collecting duct function characterized by inability to acidify the urine in the presence of the systemic acidosis. And the classic findings include hypocalcemic, hyperchloremic, non-anion gap metabolic acidosis, along with nephrolithiasis, nephrocalcinosis, and elevated urine pH, which is greater than 6. The second type is the proximal one, and it is characterized by the defect in the bicarbonate reabsorption and associated with initial high urine pH that normalizes as the pH bicarbonate decreases and the amount of filtered bicarbonate falls. Nephrolithiasis is uncommon in this disorder owing to relatively normal urinary citrate excretion and growth retardation, and hypocalcemia in children resulted from metabolic acidosis. The third one is type 4 distal, and this type 4 renal tubular acidosis is associated with chronic renal disease in patients with interstitial renal disease and diabetic nephropathy. Patients with type 4 renal tubular acidosis can still generate acidic urine in response to acid challenge, and renal stone formation is uncommon, but patients with type 4 renal tubular acidosis have significant lower urinary pH and decreased urinary calcium excretion compared to the normals or compared to the controls. This is another stone, struvate stone or stone infection stones. So infection stones are composed primarily of magnesium ammonium phosphate, hexahydrates. This is the chemical formula for this stone. So that many in addition contain calcium phosphate in the form of carbonate acetate. Additionally, they may have some form of calcium acetate. And the Swedish geologists discovered the name the struvate, and first theorized that bacteria split urea. The mechanism is that the bacteria split the urea, thereby setting up the condition for stone formation. And here latter is isolated the proteus vulgaris from the stone. So this is schematic representation of struvate stone formation. So in this stone formation, the bacteria, especially the proteus mirabilis, there are also other bacteria, has an important role in the formation of the stones. When it is a bacteriology in these infection stones, the most common urea-producing pathogens are Proteus, Klebsiella, Pseudomonas, and Staphylococcus species, and Proteus mirabilis is the most common organism associated with the infection stone. Although Escherichia coli is common cause of urinary tract infections, rare species of can produce urease, and bacterial urease can be detected by urea rapid test and urea indole medium from the biomerex. Bacteria may be involved in stone formation by damaging the mucosal layer of the urinary tract, resulting in both increased uh, crystal adhesion and denucleation. When you see the anatomical predisposition to the stone, as I have said, this is a risk factor for stone formation. The first anatomical predisposition that causes that predispose for the stone formation is uretero-pelvic junction obstruction. So the incidence of renal calculi in patients with uretero-pelvic junction obstruction is nearly 20%. So the type and the distribution of metabolic abnormalities identified in these patients were similar to those of general stone formation population. So they like hypercalciuria in 46 patients percent of patients, hyperuricosuria in 11%, hypercitraturia in 30, and primary hyperparathyroidism in 13%, and renal tubular acidosis 3%. The other is the horseshoe kidney. So horseshoe kidney occurs with the prevalence of 0.2%, but this is the occurrence of horseshoe in general population, but has an associated renal calculi of 20%, also 20% contribution for the formation of renal stone. The impairment of renal drainage in this condition is predisposing to the upper the uretero-pelvic junction obstruction because of high insertion of ureter into the renal pelvis in case of horseshoe kidney. So therefore, the risk of stone formation has been attributed to urinary tests rather than metabolic derangements. In this case, the renal urinary stasis is the cause than metabolic derangements in horseshoe kidney. The other is medullary spongy kidney. So the medullary spongy kidney is a disorder characterized by ectasia of renal collecting ducts and nephrocalcinosis and renal calculi are frequent complications of medullary spongy kidney. The most frequent complications for medullary spongy kidney, renal calcinosis, renal calculi. So the exact risk factor for stone formation are not clearly understood by the medullary spongy kidney, but renal tubular defects and defective urinary acidification after ammonium chloride load have been detected in some the medullary spongy kidney patients. Summary, so the urine must be supersaturated for stone formation to form, and supersaturation alone is not sufficient for crystallization to occur in the urine, owing to presence of urinary inhibitors. Nearly 80% of renal stone is component of the calcium, and the common calcium stones may originate from the subepithelial plaques composed of calcium epitheliate, and the non-crystalline components of the stone is a matrix, which is composed of combination of mucoprotein, proteins, and carbohydrates. These are the reference for my presentation. Thank you for your.
Yes. Okay, thank you, Dr. Inchalo. It was a very nice presentation. I don't have much to add because we are going to repeat in the second session, in the management session. As we said, stone disease is one of highly prevalent urologic problems globally, as well as in our setup, probably next to prostate pathologies. That is stones, that is a common problem in our setup as well. So stone formation is dependent on balance between the pH, the hydration status of the patient, the promoters and the inhibitors of stone. So you have mentioned different risk factors to cause renal stone, and you have tried to mention the different stone types. And as you mentioned, the most common cause of, the most common type of stone is calcium containing stone, especially calcium oxalate stone. This stone is has a wide range of pH. It can be formed in acidic urine, in alkaline urine, and so on. So, as you mentioned, there are different types of hyperoxaluria, and hyperuric calciuria. So, calcium in the urine may be due to absorptive type of hypercalciuria, or it may be renal leak, or it may be due to high absorption in the GI. So differentiating or classifying like this has its own management importance. And in addition to hypercalciuria, hyperoxaluria is also an important finding in calcium stone formation. It's not only hyperoxaluria that causes stone, it has to be hypercalciuria. So hyperoxaluria, they have equivalent role in forming calcium oxalate stones. Hyperoxaluria, it can also cause tubular injury, as you mentioned, that may help in fixation of these crystals. If there is no fixation, there is no stone growth. So fixation is important. So hyperoxaluria has its own importance in causing tubular injury and promoting fixation of crystals. Uh, as you mentioned, this tubular acidosis. Can you come? So renal tubular acidosis, it is type 1 or the distal renal tubular acidosis, which is the most common cause of renal stone. It is due to failure of excretion of hydrogen ions in the distal tubules. So that will cause systemic acidosis, but the pH in the urine is really high. So in this condition, the urinary pH is very high. We expect stones that are formed in the higher urine pH, like phosphate stones. Okay. And as you mentioned, infection stones are also very important, especially in women. Uh, uh, and these stones, the management, when you come to the management, it needs really treating the infection and clearing all the stones, okay, all the stones, and addressing the reason for the infection. So I don't have much to say. So if you have any question or suggestion, you can forward and we can proceed to the next, the management part. So audiences, you can forward the questions.
Slide observation percussion. Slide observation percussion. Observation percussion and sustainable no type 1 type 2 type 3 ከሶስቱ አንዱ calcium diet dependent. Calcium diet dependent. This is when you take high calcium, there is high calcium urine level. ሌሎቹ ግን they are not dependent with calcium diet. ብዙም ወሰድም whether it is low calcium containing diet or whether you take high calcium containing diet, conservative hypercalciuria ይኖራል። ዳይት ዲፐንደንት የሆነው በጣም ሬር ነው። 15% ዳይት ካልሽየም ዳይት ኢንዲፐንደንት የሆኑት ናቸው የሚበልጡት። አንተ ግን ፎከስ አድርገህ ያወራኸው ከካልሽየም ዳይት ጋር አሶሲየትድ ስለሆነ ብቻ ነጥለህ ነው ያወራኸው። ስለዚህ በዚህ ምክንያት I said this because I have a reason. High calcium diet is protective for stone formation. High calcium diet is protective for stone formation. ምክንያቱም ካልሽየም ዲፐንደንት የሆኑት ሃይፐርካልሲሚያ ሬር ስለሆነ አብዛኞቹ ኢንዲፐንደንት ስለሆኑ እንዲያውም ካልሽየም መውሰድ is protective for stone formation. ስለዚህ presented only there are some types of observed hypercalciuria, but you presented about the rare type of observed hypercalciuria.
Okay. Any more, Dr. Geta? So you can finish.
No.
That's all. Okay. I think the audiences may not hear you, Dr. Gitasa, what you said. Now it was audible there? Okay, that's good.
So anyone who has a question can forward.
So, anyone with questions, please raise your hand.
So in that case, we can finish our seminar now. We'll come to the next session after 15 minutes. This is the management session.